Hi folks, my name is Maruf, and today I wanted to talk to you about a very high yield topic for the PANCE boards, and that is EKG interpretation. Now, EKGs can feel pretty overwhelming, but board exams only test a handful of EKG patterns. So in this video, I'll review the most common EKG patterns that you need to know for the boards, and then I'll show you a quick and easy way to tackle EKGs that's useful for both the boards as well as for clinical practice. Let's jump right into it. We'll begin by talking about the most sexy topic on the boards, and that is STEMIs, or ST elevation myocardial infarctions. Now, acute coronary syndrome is a very broad topic, but for the sake of time in this lecture, we're going to keep it nice and simple and only highlight the most important features of STEMIs. Now, the first thing I do when I'm looking for STEMIs on an EKG is scan through each individual lead and see if there are any ST elevations above that isoelectric baseline. If ST elevations are present in at least two contiguous leads, then I know that I'm dealing with a STEMI until proven otherwise. The management for these patients is pretty straightforward. The most important thing that you need to do is activate the cath lab. There is a potential blockage within the coronary arteries, so going in there with the catheter and opening up that artery is the most important intervention that you can do. Now, while you're waiting for this patient to be taken to the cath lab, you also need to be giving your patient aspirin, another antiplatelet like ticagrelor or clopidogrel, although ticagrelor is preferred, and IV heparin. In addition to knowing the management for STEMIs, it's important to know how to differentiate the territories that STEMIs can present in. When there's a blockage of a coronary artery, there are EKG changes that occur in specific leads that will then help you predict which artery is occluded. So for example, if you see ST elevations in leads V1 through V4, you're likely dealing with a blockage of the LAD artery, causing an anterior left ventricular MI. Now, patients can also suffer MIs that are specifically in the septum of the anterior part of the left ventricle, and that will manifest as EKG changes in V1 and V2 on the EKG. Now, you can also see ST elevations in leads V5, V6, 1, or AVL, and that will indicate that you're dealing with a blockage of the lateral circumflex artery, causing a lateral left ventricular MI. Now, if you see ST elevations in leads 2, 3, or AVF, you're likely dealing with a blockage of the right coronary artery, causing an inferior left ventricular MI. Now, I do want to take a little second here to talk about pericarditis, since ST elevations can also be seen in patients dealing with diffuse inflammation of that pericardium, like in pericarditis. The key difference, though, between patients with STEMIs and patients with pericarditis is that in STEMI, you have an actual death of cardiac tissue due to a vascular blockage, while in pericarditis, you have very nonspecific, diffuse inflammation of the sac around the heart with very little damage to the actual myocardial tissue. This is what differentiates the EKG pattern of a STEMI versus a pericarditis. Since STEMI has to do with the vascular occlusion, the parts of the heart that are going to die will follow a territorial pattern, while pericarditis deals with diffuse inflammation, so there's no specific pattern of injury, and instead you're going to see ST elevations that will also be diffuse and nonspecific. So if I see an EKG pattern with diffuse ST elevations, and also with the classic symptoms of pericarditis like pleuritic chest pain or pain that's worsened with leaning forward, then I'm more likely to think that the patient is suffering from pericarditis and instead treat them with things like NSAIDs and colchicine. While on the topic of STEMIs, it's important that we talk about the right coronary artery. The right coronary artery is particularly interesting because in addition to supplying the inferior wall of the left ventricle, it also supplies the right ventricle in about 50% of the human population. In addition to that, it also supplies the cardiac conduction system in a majority of people. So if you have a patient with an inferior wall MI, they're often experiencing additional issues of a right ventricular MI, as well as bradycardia from a dying conduction system. So it's really important that we try to identify these people who are having right ventricular wall MIs because they don't do well with low preload. The right ventricle is considered preload dependent. And so when it becomes very stiff and dilated, like when it suffers an MI, the heart needs as much preload as possible to ensure that there's a continued flow of blood out of the heart. So for that reason, it's important that we don't give patients with right ventricular MIs any nitrates, since nitrates normally lower the preload, causing venodilation and allowing more fluid to stay within the venous system and away from the actual heart. So a pretty good rule of thumb is if you have an inferior wall MI, you're probably dealing with a right ventricular MI, in which case do not give nitrates. Now listen, we have so much more that we can talk about when it comes to STEMIs, but to respect your time, we're going to keep moving forward with the EKG review. And if you want any dedicated video on ACS, feel free to request in the comments, and I'm happy to work on that for you guys. In addition to STEMIs, another common topic on the boards is tachyarrhythmias. So if I see evidence of a fast heart rate on an EKG and I don't see any P waves, I know that I'm likely dealing with one of four tachyarrhythmias. If it's irregularly irregular, that's atrial fibrillation until proven otherwise. Meanwhile, if it's a regular rhythm and a rate of 150, that's probably atrial flutter. If it's a regular rhythm and a rate of 150 or more, like 170s, it's probably supraventricular tachycardia. Meanwhile, if it's a regular rhythm and a rate less than 150, it's probably going to be sinus tachycardia. It's sometimes hard to see P waves in a really fast sinus tach because they get buried within the previous T waves. But in reality, it is going to be sinus tachycardia in a majority of these cases. Lastly, if I see a wide complex tachycardia, that is a ventricular tachycardia until proven otherwise. Atrial fibrillation is the most common cause of a narrow, complex, irregular tachycardia. For that reason, if I see such a rhythm on an EKG, I'm immediately thinking atrial fibrillation. Now, in atrial fibrillation, not only do you have an irregular rhythm, but you also lose your classic P waves. Instead, you're going to get these fibrillatory waves, or waves that look like they could be P waves, but not really. So in atrial fibrillation, what's going on is that you have these ectopic beats that are being generated within the pulmonary veins, and they end up taking over the rhythm. So this leads to the loss of your P waves, and instead you get this very erratic, irregular heart rate that can sometimes become very tachycardic. To manage atrial fibrillation, first you need to determine if you're dealing with a patient that's stable or unstable. If the patient's unstable, like hypotensive or obtunded, you want to immediately electrocute that person using synchronized cardioversion, a little Pikachu action. Now, if the patient is stable, then you don't need to be as aggressive, and instead you can use medications like metoprolol or diltiazem, both of which will slow the conduction through the AV node and therefore slow the heart rate. Now, after you're taking care of the heart rate, you can decide on anticoagulation for the patient. The problem with AFib is that it increases the risk of clot forming within the left atrial appendage, and this clot can shoot out into the systemic arteries. So you can get like a stroke, mesenteric ischemia, limb ischemia, etc. So it's important that you calculate the patient's CHADS VASC score and determine if they should receive blood thinners if they're at a high risk of developing an embolic stroke. So if we have an irregular rhythm, most likely we're dealing with AFib. Boom, on to the next question, right? But if we're dealing with a regular rhythm, then we're probably dealing with ventricular tachycardia, atrial flutter, SVT, or sinus tachycardia. And this is where we can look at the rate and QRS width as a way to help us differentiate between these different arrhythmias. So for example, if I have a narrow QRS and a heart rate around 150, then I'm most likely going to be dealing with atrial flutter. In atrial flutter, you have this abnormal reentry circuit such that when an electrical impulse gets trapped in this abnormal circuit, it starts to go really fast, like 300 beats per minute within that atria. But in reality, only a set number of these waves can actually get through to cause a ventricular response or a QRS complex. So most commonly, we're going to see what we call a 2-to-1 pattern of atrial flutter. Basically, for every 2 flutter waves that are generated, only 1 creates a ventricular response in the form of a QRS complex. So you can see in this animation over here, every 2 laps that this little flutter wave makes around the circuit, only one of them actually makes it through the AV node and into the ventricles. So since the flutter waves go at a rate of about 300 beats per minute, mathematically this causes a ventricular response of 150 beats per minute if you're only sending every other beat in. So whenever I see a heart rate of 150 and it's regular rhythm narrow complex, I'm immediately thinking atrial flutter. Now it's pretty easy to see those classic flutter waves or sawtooth waves of atrial flutter when you have like a 3-to-1 or a 4-to-1 pattern, because there are many more flutter waves that you can actually see. Meanwhile, when you have a 2-to-1 pattern, the flutter wave kind of melds in with the T wave, and it can make it a little bit more difficult to see what you're dealing with. The management of these patients with rapid A-flutter is going to be very similar to that of rapid AFib. If the patient is unstable, you're going to go ahead and synchronize cardiovert the patient just like you did in atrial fibrillation. If they're stable, then you don't need to electrocute. You're just going to give them a rate-lowering medication like metoprolol or diltiazem. And then lastly, you're going to consider their stroke risk using that CHADS-VASc score and determine if they need to be on blood thinners. Now, what if you're dealing with a regular rhythm tachycardia, but the heart rate is greater than 150? Well, that usually means that you're dealing with a paroxysmal SVT or PSVT. In SVT, you have an electrical impulse that gets trapped in the AV node, causing it to transmit every single electrical impulse to the ventricles and producing a very fast heart rate, usually like 170 or more. Now, this pathophysiology might sound similar to atrial flutter, but instead of that re-entry circuit that we had in the atria, like an atrial flutter, here the AV node itself is going to act as a re-entry circuit. Now, when you've recognized an SVT on an EKG, the first thing you need to ask yourself is the patient stable or not? If they're unstable, light them up with synchronized cardioversion, just like you did with unstable AFib and A-flutter. On the other hand, though, if they're stable, the boards want you to perform vagal maneuvers first. And if that fails, then you're going to go to adenosine. Now, in reality, I often find vagal maneuvers don't work, and I usually go pretty much directly to adenosine. The way that adenosine is going to work is that it will completely block the AV node, and therefore basically extinguishing that electrical impulse that got stuck in there, and now allow for that SA node to take over again. Now, what if the EKG shows a regular tachycardia with a heart rate less than 150? Now, that usually means we're dealing with a sinus tachycardia. And we know this because the SA node, which sets the sinus rhythm, usually doesn't fire faster than 150 beats per minute while a person's at rest. So usually if I see a regular tachycardia and a heart rate less than 150, I often know that I'm dealing with a sinus tachycardia instead. Now, sinus tachycardia is usually a compensatory act. That means that the heart is becoming tachycardic in response to some sort of underlying stressor to get more blood to our organs. That stressor could be infection, it could be dehydration, pain, anxiety. So it's important that we make sure to look out for these key features like fever or dehydration, which would significantly increase the chances that we're dealing with a sinus tachycardia. Now, the treatment for sinus tachycardia will focus primarily on treating the underlying cause, whether that's infection, dehydration, etc. So in clinical practice, when we see improvement of the heart rate after giving things like IV fluids for dehydration, Tylenol for fever, we know we're usually dealing with a compensatory sinus tachycardia. Now, what if instead of a narrow complex tachycardia, you see a wide complex tachycardia with a QRS greater than 120 milliseconds? Well, in this situation, you should presume that you're dealing with ventricular tachycardia until proven otherwise. In VTAC, you'll see a fairly organized appearance to the ventricular waves on the EKG, kind of like a lineup of pine trees. Now, ventricular arrhythmias usually occur in hearts with either dead or fibrotic ventricular tissue. That dead tissue leads to significant architectural changes, and this leads to the formation of abnormal reentry circuits. Think about the reentry circuit issues that we saw in atrial flutter and SVT, but here the reentry circuits are being created by dead tissues in the ventricles. Now, normally, healthy cardiac tissue allows for electrical impulses to go through in a very smooth, straight line. In unhealthy tissue, though, signals are more likely to get trapped within abnormal reentry circuits, and it makes it much easier for arrhythmias to generate. All it takes is a poorly timed beat to disrupt that normal rhythm and then send the patient into one of these ventricular arrhythmias like VTAC or VFib. When managing ventricular tachycardia, the treatment is going to be determined by the hemodynamics of the patient. So for example, if the patient has no pulse, go ahead and defibrillate them. Then continue ACLS measures with compressions, epinephrine, and IV amiodarone. It's important that you remember that a pulseless VTAC is one of the only two rhythms that we shock. Now, if the patient has a pulse but is unstable, for example, hypotensive, obtunded, then we deliver a synchronized cardioversion instead. This is very similar to all the other unstable tachyarrhythmias, like we talked about atrial flutter, atrial fibrillation, and SVT. Meanwhile, let's say the patient is stable, then you don't have to be as aggressive with electricity, and you can try amiodarone or procainamide as an IV form instead. All right, so far we talked about patients who are alive with a pulse, whether stable or unstable. But what if you have a patient that is instead pulseless or dead? In that case, there are a total of 4 rhythms that you need to be aware of. Now, we already talked about the first rhythm, pulseless VTAC, and how it requires defibrillation as the mainstay of treatment. The only other pulseless rhythm that's going to require defibrillation as the primary treatment is ventricular fibrillation. Now in VFib, you have a rhythm that looks a lot like VTAC, but much more chaotic and disorganized. I like to think of it as like a toddler drawing across your walls with a marker. Whether you're dealing with pulseless VTAC or just straight up VFib, the treatment's going to be the exact same, and that is to defibrillate them and then continue CPR. The other 2 pulseless rhythms that you need to know about are PEA and asystole. In PEA, you have a patient who's essentially suffered cardiac arrest, but their cardiac conduction system is still trying to give off some final signals in the hope of getting a contractile response, but obviously failing. The rhythm looks normal, but you clearly have a pulseless patient in front of you. In asystole, you again have a patient in cardiac arrest whose rhythm strip just looks like a flat line. There's no signs of electrical activity in it whatsoever. In either of these cases, electrical intervention just does not work, so you do not shock these patients. Instead, the most important thing you can do is just perform CPR with good chest compressions and rounds of epinephrine. The final thing I want to talk to you about in this EKG lecture is AV nodal heart blocks, which are a pretty popular topic on the board exams. Now, heart block essentially occurs due to chronic coronary artery disease or AV blocking medications. The coronary arteries feed all parts of the heart, and that includes the conduction system through the right coronary artery. So if patients have coronary artery disease, the conduction system becomes hypoperfused and over time slowly deteriorates. Now, some patients may develop heart blocks because of the medications they take instead, like beta blockers or calcium channel blockers, both of which innately slow the conduction through that AV node. Heart blocks can be broken down into subdiseases where, as the degree of the AV nodal disease gets worse, so too does that degree of heart block. At its mildest form, a patient might develop first-degree heart block. In first-degree block, you have AV nodal disease that's caused a slight delay in the time that it takes for the signals to get transmitted through the AV node, but the job still gets done. Here, the PR interval is longer than 0.2, but there are no dropped beats. So these patients are usually asymptomatic and really don't need any specific treatment, just monitoring. The best thing you can do is just manage the patient's underlying coronary artery disease or the medications that might be causing their first degree AV block. When we're dealing with second degree heart blocks, we have even worse disease of that AV node, so now we're actually getting dropped QRSs or dropped beats. You can imagine that if your heart is dropping or skipping beats from time to time, you're going to have an effectively lower heart rate. And likewise, that's going to lead to a lower cardiac output. So you're actually more likely to have symptoms like lightheadedness, chest pain, basically all the symptoms that come with low cardiac output. So there are essentially 2 types of second degree heart blocks that you need to be aware of, and that's type 1, also known as Mobitz 1, and type 2, also known as Mobitz 2. In type 1, you have a PR interval that's going to get progressively longer until you essentially get a dropped QRS, or a pause within that EKG rhythm. In type 2, also known as Mobitz 2, you have a steady PR interval. It doesn't change, but every now and then you randomly drop a QRS. When you're managing Mobitz 1, you're going to take the same approach as you did with first degree heart block, and that's to just treat the underlying disease. And that could be the coronary artery disease or the culprit medication. With Mobitz 2, evidence shows that there's actually a fairly high risk of progressing into complete heart block. So these guys actually need a permanent pacemaker as their definitive management. When you have a third-degree heart block or complete heart block, you have such bad AV nodal disease that now there's a complete disassociation between the atria and the ventricles of the heart. So by nature, there's complete disassociation between the P waves and the QRS waves. You'll see that the P waves are evenly spaced apart and the QRSs are also evenly spaced apart, but there's no actual relationship between them. That's going to cause the atria to go at their own intrinsic rate of like 60 to 100, and the ventricles to go at their own intrinsic rate of about 20 to 40 beats per minute. But since only the ventricular rate actually creates an actual cardiac squeeze, these patients are going to be inherently bradycardic. That slow heart rate then is going to create symptoms of hypoperfusion with low cardiac output. So you're going to see things like chest pain, lightheadedness, and hypotension. So a pretty good rule of thumb is that if you see a heart rate in the 40s or even lower, then that's probably a complete heart block, or at least start looking for that PR dissociation. Now, most patients with complete heart block will require a permanent pacemaker as their definitive management, but a lot of times these patients present fairly symptomatic already, in which case you're going to give them atropine as their first line of management. If that atropine doesn't work, you can try transcutaneous pacing, and essentially your goal is to stabilize them until you can get them to their definitive management, which is that permanent pacemaker. If you found this video helpful, then be sure to check out part 2, where I go over a stepwise approach that you can use to evaluate any EKG on the boards, followed by some examples, of course. I'll see you there.